All right, well, why don't we get started now? It's 12:01. So, hello everyone, my name is Rob Ballo, and I'm going to be moderating today's session that will be a presentation by Cynthia Foster-Gibson. And before Cynthia gets started, why don't we get some introductions from everybody that's participating, starting with, well, we'll do it in alphabetical order from top to bottom with Camille.
Hi, my name is Camille Vigla, and I'm a healthcare facilitator for the Northeast, and I am in Sturgeon Falls.
Can you also tell me if you are alone in the room or if you are with a group there?
I'm by myself.
And Dawn?
Hi, you guys hear me?
Yep.
Oh, great. So Dawn Robitaille, we're at the Douglas Hospital in Montreal, and I will be joined by some colleagues. We're going to be muted throughout this time because our patients can be very loud, so we don't want to disrupt the session. So.
Do you know who will be joining you?
Yes, both of our social workers, Alexandre and Elena.
Social workers, okay. And sorry, David, go ahead, give your introduction.
David Jory, St. John, New Brunswick, parent, on my own.
Okay, Denise?
Hi, I'm Denise. I'm an occupational therapist in the dual diagnosis service in Toronto at the Centre for Addiction and Mental Health and in the Peel region as well.
Very good, thank you, Denise.
And I'm sorry, and I'm here alone, yeah.
Okay.
Okay, thank you.
Melissa? Oh, I'm skipping, aren't I? Joanne, sorry.
Hi, this is Joanne Trahan. I'm with the North Community Network of Specialized Care. I'm a coordinator, and I'm situated in North Bay with HandsToFamilyHelpNetwork.ca.
Thank you, Joanne. And who's next? Kathy.
I'm Kathy Ryan. I'm an advanced practice nurse at Center for Addiction and Mental Health. I'm in the complex mental illness program.
Very good. Thank you, Kathy. Ken?
Hi there. I'm Ken Boss. I'm a psychiatrist working in the Developmental Disabilities Service in North Bay.
Thank you, Ken. I'm writing all this down very quickly because Susan asked me to keep a list of everybody, so North Bay. Okay, and Melissa. Hello, Melissa?
Hi, can you hear me now?
Yep.
Melissa Meyer, mental health clinician and behavioral consultant with Developmental Disabilities Mental Health Services in Burnaby, BC, near Vancouver, and I'm joined by another behavior consultant and one of our mental health nurses.
And her name is?
Katie Brown is the nurse, and Ryan Basilak is the other clinician.
And sorry, can you tell me what the organization is that you're from again?
It's Developmental Disabilities Mental Health Services. It's part of Fraser Health Authority.
Okay, very good.
Thank you.
Where are we now? Geez, that's pretty good to show up. Roseanne.
Hi, Rob. Yeah, this is Roseanne Stein. I'm with the North Community Network of Specialized Care. I'm a knowledge exchange coordinator, and I'm in Bracebridge, Ontario.
Welcome.
Thank you.
And I think lastly, Sharon. Sharon Chandler. is having some communication problems. Tony, do you want to introduce yourself?
I am Tony. It looks like you're muted right now, so there's a little icon like a microphone that you can click to unmute. Hopefully that's all it is.
All right. Well, Sharon, when you get that figured out, you'll be able to introduce yourself. So Cynthia has actually suggested that she's happy to take questions as she's presenting. Tony, is there a way to raise hands or to alert people that they'd like to ask a question?
Not that I'm aware of with this software, no.
Right. Okay. So there's the chat area there that we can certainly alert Cynthia that we're interested in asking a question, or you can actually type out the question in that chat area directly, and I'll keep an eye on that as Cynthia is presenting. So Dr. Cynthia Foster-Gibson went to Western, I guess what used to be called the University of Western Ontario, to get her MD degree, then obtained her PhD from the University of Windsor, and did postdoctoral work in genetics and in developmental disabilities at Queen's. At Queen's University, she was a member of the Division of Developmental Disabilities and part of the Autism Research Project. And I noticed, Cynthia, that you didn't put any years for any of the information that you provided there for me. Is there a reason for that?
No, not really.
Okay, very good. And Cynthia is going to be presenting on what's in a name, the value of knowing the cause of developmental delay. So go ahead, Cynthia.
Okay. Currently I'm in Mississauga at Credit Valley Hospital in the genetics program. And I am a GP, and I work in clinical genetics. So my practice is solely to do with genetics. I see lots of kids and adults with developmental delay, some with autism, but not all. My role essentially is to find out the cause of the developmental delay for the person that I'm seeing, child or adult. And so I wanted to give you an idea as to why we care. Typically when somebody gets referred, it's often to try and find out what the recurrence risk might be in subsequent pregnancies, that sort of question. But I look at it a little differently because to me the greatest value in knowing the cause of developmental delay, sorry for the overhead here. The greatest value really is to understand what might be affected, so that if you know the genetic etiology, you can sometimes identify what sort of medical issues you might come across, or perhaps what kind of behavioral issues, and if there are specific ways of addressing those concerns. Now, there we go. So my objectives then are to give you a sense of what the challenges are and what the benefits are, to try to find an etiology, and then to look at where you might get resources in order to try and help an individual once you do identify a genetic etiology. I put this slide in because it's a picture of lung cells, and it reminds me that all of the cells have the same genetic information, but some of them have different genes that are activated, and some genes will alter structure, so the cells look a little different. So you can see this cell here has cilia, which are waving around, clearing things out of the lungs, and these ones don't. So structurally, there's a difference in appearance, and there's a different function related to the gene activity in those cells. And so some of the etiologies that we look at are single cell changes, and some have more than one gene, sometimes a whole chromosome. So you're looking at a lot of different genetic mechanisms that can be involved. Okay, so if we think about a single gene, and you think about how a gene works, most genes code for some type of protein. And this was came out of an article in The Guardian a few years ago where they talked about the Brussels sprout gene. So for those of you who like Brussels sprouts, it might be because your PTC receptor doesn't detect the bitterness in the flavor of a Brussels sprout. So you can have this gene which codes for a receptor, and if it's the right shape, it will grab onto the PTC molecule and you'll taste bitterness. But if the receptor isn't quite the right shape, you don't taste as much bitterness, or maybe you don't taste any at all. So that gene has an effect on how you perceive the taste of PTC or Brussels sprouts. So that's sort of looking at single gene effects. The terminology is changing a little bit in the sense that when we talk about mutations, from a geneticist point of view, a mutation is just a change. So it's a genetic change, and it may be pathogenic, in which case it's disease-causing. It may be benign, so it doesn't create any issue at all, and the other term for that would be polymorphic. Those kinds of changes we all have. In fact, we all have pathogenic changes, and we all have benign changes, and we have lots of them, but we don't always know that we have them. The other category that is becoming a much commoner part of my terminology in the genetics clinic is a variant of unknown significance. Because our testing has become much more, much broader, much more complex, we can do a lot of tests, but we can sometimes get a result that says this has changed and we don't know if it's benign or pathogenic. Come back in 5 years, maybe we'll know then. And that's happening more and more as we get into more complex genetic tests. So we talked a little bit about having the loss of a number of genes, and Williams syndrome would be a condition where that's typical. So these are genes that are physically linked, which is what contiguous just means, that they're all together in the chromosome. And this happens to be in chromosome 7. I don't know why I have that funny little, well, I can't get rid of it. So in this portion of chromosome 7, there is a small region with these genes missing. And the gene in here, which I don't know if you can see or not, that's elastin. And the elastin gene is the one that in Williams syndrome causes cardiovascular complications. So that gene is important for that feature of Williams syndrome. There are some genes down here that seem to be involved in the appearance. So kids and adults who have Williams syndrome tend to have similar facial features, and some of the genes down here are involved with how the face is formed as they're, well, from the point in time of conception. The shape of the face is controlled by some of the genes down here. Not all of these genes always have to be missing to have Williams syndrome, and you can have atypical deletions, so smaller deletions, and still get Williams syndrome. If all you're missing is the elastin gene, then you get the cardiovascular issues, but you don't get a lot of the other features. Maybe some learning issues, but often not that either. So that's another thing that we see, and we're seeing this much more often because we're doing a new test called a microarray, and microarrays look for those kinds of things. Small regions of a gene that are missing that you can't see looking under a microscope, but you can detect by using DNA techniques. So this is a picture really of four kids who have different genetic changes. This little girl has a duplication of a portion of chromosome 22. This boy has a deletion of a portion of chromosome 22, and this would typically be referred to as velocardiofacial syndrome. Sometimes it's called DeGeorge. Sometimes it's called 22q11.2 deletion syndrome. So it's got a bunch of different names. And I'm going to talk a little bit more about that later on. This individual is missing part of chromosome 17 and has a condition that is called Smith-Magenis syndrome. And then this little guy is missing part of chromosome 7 and has Williams syndrome. They're all examples of contiguous gene changes. Okay. So when somebody is referred to the genetics clinic, there are things that I look for, and some of them have to do with the medical history and the developmental history, the family history certainly, and some of them have to do with what I might recognize as being a characteristic pattern, maybe in the face or maybe some other physical features. And more behavioral patterns are helpful from my perspective in thinking about what kind of condition to test for. And then what I hope is that I will be able to find something where there's a lot of information on natural history, and because that'll give me the most useful information for medical concerns and how you might look for those, particularly if you have someone who has a lot of difficulty communicating. It's helpful to know what medical issues might be a concern when you're not quite sure what the problem is, but you know there's a problem, a health-related problem. It's a little trickier when you start thinking about behavioral phenotypes, just another word to say what kind of behavior are you seeing. There are some conditions where this is a much stronger characteristic, but even in that situation where you see certain types of behavior, so for example in Smith-Magenis syndrome, it's fairly common for kids and adults to pick at their nails to the extent that they pull the nails off, so fingernails or toenails, and it can be something that they do quite a lot. So it's fairly characteristic for somebody who has Smith-Magenis, but it certainly isn't exclusive to that. Lots of other people can do that who don't have Smith-Magenis syndrome, but it helps direct your thinking. And we really don't have a lot of understanding about one gene, one phenotype, although that's starting to happen more and more as we look at things like the contiguous gene changes, and we look at overlapping segments that are missing in the same area of the chromosome. Sometimes you can narrow the search down to finding a single gene that might be related to, for example, schizophrenia. And those sort of neurocognitive, neuropsychiatric problems are ones that are getting a lot of attention in research to try and find what genes contribute to that kind of behavioral or psychiatric concern. And the other thing you have to keep in mind is even if you're looking at a single gene, as you would be for, say, Fragile X, you've got 25,000 genes. And so that single gene may have a really strong effect in certain areas of the body, in the brain, but you have lots of other genes, and they're all acting out their roles as well, so they may be modifiers. And when you think about someone who has a Fragile X syndrome, probably about 30% of those individuals could be diagnosed classically as having autism. And that might be how they're diagnosed first, is to say they have autism. well, the other 70% don't seem to have autism. And the question is, why is that, given that they all have the same change in the same gene? And at least some of that is probably due to the interaction with the rest of the genes, the rest of those 25,000 genes in your body. Okay, so I wanted to go through a few situations, and these are descriptions of people that I've known during my practice, or combinations of people, and they're really just to sort of illustrate, hopefully, why it's helpful to find out the cause of the developmental delay. So if we start with Susan, who's 25 years old, she has developmental delay. She doesn't have any family involved, so we don't have family history. That's what Citizen of the World refers to. She's in pretty good health, but she moved recently to a new group home and as soon as she moved in, she destroyed her furniture. She was quite aggressive with the staff members, and she was really, really distressed. After a while, she settled down a bit, but she still had flare-ups. And in between the flare-ups, she would be quite engaging. So she was developing, the staff were developing a good relationship with her, but then these flare-ups would happen and it would be a big meltdown. So some of the things that the people were noticing, though, were that she wasn't sleeping well at night. She'd be up, wandering around, and she'd be sleepy during the day. She'd started to gain some weight. And because of the behavioral concerns, she had been put on risperidone and chlorpromazine, hoping that would help, but it really hadn't made much difference. So this is kind of a rhetorical question. Anybody who wants to answer is welcome to, but the question now is, how are you going to help her? Because everybody's distressed in this situation. So we're assuming she has a primary care provider, and that this person refers her to genetics. When somebody gets referred for genetics, there are pieces of information that you want. You want as much as you can have about their past medical history. Prenatal, if you can get it, often with adults that's impossible to do. Developmental history is helpful. Behavioral characteristics, particularly in this situation, are helpful for the geneticist to try and put together a picture and think about what they might want to test for. It's really, really helpful when somebody comes to a genetics appointment. In this situation, particularly an adult, if they come with somebody who knows them well, because then you can begin to pull out particularly some of the behavioral things that are helpful. The other thing that will happen during a genetics assessment is there will be a physical exam. And this is really directed at looking for often very minor physical features that might put together a picture. So you might be looking at whether the eyes are set a little closer together or a little further apart. Maybe you're looking for a pit in the ear or a curve in the finger. None of them are functionally significant. So it's not going to affect anybody's function. But when you put it together, you may be able to get a picture that tells you, it gives you some information about what to look for. So this would be maybe pictures of Susan as a baby and growing up. One of the things that you notice when you can see her arms is that she does a lot of skin picking. Looks like maybe she picks at her nails. They're pretty red looking. Her fingers are a little bit short. She's got a bit of a curve in the fifth finger. She's got what people refer to as wide sandal gap, so the distance between her big toe and her second toe is kind of wide. And if you were able to sort of see her in profile, you might notice that as she's gotten older, her eyebrows, you can't tell in this picture because of the glasses, but her eyebrows are probably pretty bushy, and her chin has become much more prominent. So there are a few little clues there. And if you had been told that she picked at her fingernails, and that we already know the story about the sleep problems, and that she has a lot of difficulty with controlling her emotions, so she's pretty impulsive. So those things are all characteristic of Smith-Magenis syndrome. So it would be one of the things you would think about testing. And you're looking for the loss of genetic material on chromosome 17. Does anybody have any questions or comments at this point?
I wondered if she had a problem when she went into her new group home, if the problem was the actual physical environment. She didn't like the place or she didn't like the staff. And
yes.
Whether it might have been a good idea to try another accommodation place and see if that changed anything.
Yeah, I think that's a really good point. And it certainly is, by the time you get to genetics, hopefully that's all going to have been looked at, because it's going to take you a long time to get to genetics.
Okay.
Excuse me. I would think, and I don't know because I wasn't actually there at the time, I'm hoping that they addressed those kinds of issues to try to figure out what it was that was triggering her distress. And part of it, I think, was because with this condition, and actually with a lot of developmental delay, the changing without proper preparation is really difficult. And I suspect that that's what had happened, is that she didn't know anything about the place she was going to. She wasn't prepared to have the kinds of changes that were going on. And also there were expectations as to how they could, expectations as to how to try to alter the behavior. And one of the things that I think people have figured out with Smith-Magenis is that because many of the behavioral issues are sort of innate, it's more appropriate to try to change your approach to the person than to try to change the person themselves, because they don't have control. So to me, that was one of the reasons why it was worthwhile figuring out that she had this change. Because eventually, that's what ended up happening, is the people who, she ended up on a behavior management ward. And after she had the diagnosis, the people started looking at it and saying, okay, well, if the genetic change causes the behaviors and she doesn't have control, then we need to change our approach, which they did, and they were really quite successful with it. So thank you for bringing that up, David. That's great. With Smith-Magenis, there is an organization called PRISMS that has a really great website. And a lot of the websites that come up for these particular conditions are generated by the families who are looking for support. They're looking to find other people who have kids with the same issues. And there are lots of good websites out there for conditions like this. So prisms.org is a good one to go to for Smith-Magenis. From the point of view of management, one of the things we know about this condition is that people with Smith-Magenis don't produce melatonin at night. And melatonin is what should make you sleepy, get you ready to go to sleep, keep you asleep. So generally speaking, it should increase in the evening and then decrease in the morning. So during the day, you're wide awake, but you can sleep at night. And it's quite clear that people with Smith-Magenis have flipped diurnal rhythms. So in other words, they make too much melatonin during the day and not enough at night. And it seems to be fairly useful to try and use long-acting melatonin to help people with this condition get to sleep and stay asleep, because there's a huge problem with kids with Smith-Magenis who are up all through the night, and parents who are trying to deal with this. And the kids are often getting out of their rooms, maybe going out in the street, so they're not safe, maybe just getting up and getting into things to the extent that it creates a lot of problems within the family. So that one of the parents I remember talking to told me that at one point they felt as if it was sort of one of them was going to need to go to a psychiatric hospital because they were so distressed at trying to deal with this, and they were trying to sleep on different shifts. Parents often will lock the door to the bedroom to try and make sure the kids don't get out, not for themselves, but to keep their kids safe. There are all kinds of things that parents will resort to, and it's a really big problem for some of these kids and their families. The other thing that you'll find if you look at the PRISM's website is there's a lot of information about adjusting your expectation and thinking about someone with Smith-Magenis, particularly as they're going through school. You look at the body and your brain says this child is a certain age based on what you see, but their capacity for learning and so on, their intellectual functioning, you know because you're teaching them, so you know that it's not at the grade that it should be at. But what you really need to remember is that there's also a further problem with synchrony in the sense that they're often well behind emotionally. So they tend to be more like a toddler, and your expectation is they can respond to behavior management at a grade 4 level in this example, but they're emotionally, they act as a 4-year-old, and their response is the same as a 4-year-old. So you don't get what you expect using the management strategies that you would for somebody at a grade 4 level. So there's a lot of really, I think, useful information there on addressing the behavioral issues in order to get a little bit of harmony. And from a school perspective, that's really helpful within the classroom. And there are actually some people who developed a lot of this, the information, who will go around to schools and try and help teachers in looking after these kids as they're trying to learn. Now, this isn't showing up quite the way I wanted it to, and it's not at all. It's not at all for you to try and read. There's way too much on there, and it's kind of fuzzy anyway. But it's really just so that. Sorry for the overhead again. It's really just to let you know that there are guidelines for some conditions. This particular Health Watch table was put together by a group of 5 of us, and what we did was we scoured the literature really for all the guidelines that were available for this condition and tried to identify things that were common between different guidelines, and we had experts review them who had a lot of experience with particular conditions, and then published them in the tools for the primary care of people with developmental disabilities. And this all came out of the work with Bill Sullivan through Surrey Place. So what this table does, and just sort of broadly, on the left-hand side of the table, it talks about what health concerns are a little more common in this particular condition, and then talks about what you might do about it. So it's aimed at a primary care provider. Okay, so if we use that, then you might find that she has hypercholesterolemia. And in fact, teenagers with this condition have elevated cholesterol levels, which you certainly wouldn't expect and you would never measure. But they do, and so it's one of the medical issues that you need to think about treating. Urinary tract infections are pretty common, and often there are congenital changes in the anatomy of the urinary system, so that it might be worth checking to make sure the kidneys are okay and that everything's functioning the way that it should. The other thing that can happen is hearing loss, so it might be unsuspected, but doing a hearing assessment is worthwhile. So sort of going back to David's point about the changes and the stress that produces on Susan and relationships with staff and so on, one of the things that, for the particular individual that I recall is that there was a big improvement. Everybody was happier. The staff were happier, and she was happier because they could address her needs better, and they weren't expecting things from her that she wasn't going to be able to give to them in the way of modifying behavior. Okay, any questions about Smith-Magenis, or any other comments? Okay. So this is a gentleman who is in a long-term psychiatric care for dual diagnosis. So he has intellectual disability and has been diagnosed with schizophrenia. Came from a family where his father has passed away, but he has some sisters and his mom is still living. He's 42. And he's been in and out of psychiatric care since he was a teenager. You might notice something about his facial features that, particularly because you've met the family, and maybe you've seen pictures of him with his family members, and he looks a little different than his family members, which is not to say that in a pejorative sense at all. It's not. It's just that he doesn't quite fit in with the rest of the family somehow. So that might be what makes you think he has notable facial features. His speech is a little bit hypernasal, and he has been getting a lot of pneumonias. So the genetics consult shows that on chromosome 22, he's missing a piece of genetic material. And if you remember back to the slide that had the picture of the 4 kids, one of them had velocardiofacial syndrome, which is just one of the other names for this chromosome 22 microdeletion. There's a health watch table for that. And hopefully you can see, if you go to the Surrey Place website, you can access the tools for the primary care on that website. Okay, so some of the things that you think about in somebody who has velocardiofacial syndrome is that their calcium levels are often, can be low. So that can lead to problems with bone density. And people who have VCFS should always have vitamin D supplementation, and depending on the calcium levels should maybe have calcium supplements as well. And it's something that fluctuates throughout their life, so they need to be monitored to make sure that their calcium levels are okay. because he had the hypernasal speech, he went to see a speech-language pathologist. And that was really not so much for the speech, but to look at the function of the palate. So in somebody who has this condition, the palate often doesn't move the way that it should. And that creates a couple of issues. It changes the speech pattern, so it sounds a little more nasal, but it also can create problems in swallowing. And as somebody with this condition gets older, that can lead to lots of problems, because if you're not swallowing properly, then you're at risk for aspiration pneumonias. So that's something that you want to check, and we know that he's had a bunch of pneumonias, so we want to know, is that part of the issue? The other thing that can, or one of the other things that can be a concern in this condition, is that immune function can be compromised. And this can be a really big problem in the kids, but that's rare. It's more likely that it's going to be something that happens later on as somebody's getting older. And if you know that the immune function is compromised, then you're going to start doing things like the vaccinations for the pneumonia and for flu. I mean, hopefully you're doing that anyway, but the pneumonia you probably wouldn't think about in a 42-year-old. And it hopefully will make you, the doctor and whoever else is looking after him, think about taking those kinds of precautions, as well as treating respiratory infections earlier. So treating a pneumonia as soon as it starts, rather than, and being aware enough to look for the pneumonia as well. In this particular instance, this was somebody who had been in, as I said, in and out of psychiatric care for most of his life. And when he was younger, his mom basically had been told that she was the person who was the cause of his mental health problems. So it was helpful for her to know that people who have DCFS, or have this particular genetic change, have a relatively high rate of psychosis and schizophrenia of about 25%. There are other mental health issues as well. So this probably has to do with the genes that are in that region. One of them we know functions in how neurotransmitters work in the brain, and is probably related to the potential for developing schizophrenia or mental health problems with this condition. So for her, it was really helpful to know and to be able to say that it wasn't her, that this was something that he was predisposed to, and it took away a lot of her guilt. And it's pretty common for parents who are, and these, often I'm talking to parents who are in their 70s or 80s, because I'm seeing their adult children, and often the first thing that they will say is that they no longer have to worry that it was because they did something either during the pregnancy or when the child was young, and that they have always sort of blamed as being something they did to their child. And so I think it's another reason for looking at etiology. This is a condition where about 10% of the time there is a family history. So there you can see it as what's called an autosomal dominant. In other words, were this person to have kids, there would be a 50% probability at each pregnancy that the child would have the same condition. So that is sometimes something that is part of the discussion. The rest, 90% of the time, it's something that's new in that individual. So even though it's genetic, it's not something that's been inherited. There is, in Toronto anyway, a clinic that is now at Toronto General Hospital where they will do annual assessments of adults with DCFS, and it's a multidisciplinary clinic. So they have an endocrinologist, I think they have a psychiatrist, well, I'm sure they have a psychiatrist, Ann Bassett, who is really world-renowned in her knowledge of adults with VCFS. And so they look at the whole person and really use it as a consultation clinic. This is just to show you a little bit about facial features. And in VCFS, the facial features tend to be the shape of the nose, a little bit broader in the bridge. And as people get older, they get more prominent noses and longer ears. But when the more you do this test and the more you identify people who have this deletion, the more you recognize that physical features are not there in many people who have this this chromosome deletion. So it's not as good an indicator as we thought. And there is a pretty broad range in the level of developmental disability, so that many people are actually borderline and are often the people who sort of fall through the cracks. They don't get recognized and they don't get assessed. It's not uncommon, so 1 in 2,000 to 1 in 4,000. And as I said, some will have a family history. So these just list some of the systems that are involved with the palate, the immune problems, congenital heart disease, probably in about 40%, and that's sometimes how it's picked up at birth. And some of the neuropsychiatric concerns as well. And 60% covers the whole gamut of mental health issues. The schizophrenia portion is about 25%, I think. There are some great guidelines out there. Ann Bassett has put together some very useful information, and so this is primarily for adults, I think, with this deletion. Okay, any questions about VCFS or comments? Okay, so we'll go on to Eleanor, who's 14. She's got intellectual disability. And one of the things that Mom says is that she doesn't really describe her as losing skills, but she says that every time she tries to learn something, she will learn it, then she'll lose the skill, and then she'll have to relearn it. And usually she can relearn it. But there's been some regression in her ability to get around. So she's not as good as she used to be in going up and down stairs. So a little less mobility. And she has scoliosis in her spine, and it's restrictive, so it's causing problems with her breathing. So they're thinking about doing surgery to replace or to put a rod in for the scoliosis. One of the things that Mom has noticed is that she will kind of wring her hands. And essentially what tends to happen in this condition is there will be a lot of what's called midline movement. So somebody will take the hands and move them to the midline. They might not wring them, they might put them in their mouth or touch their face or something, but there's the movement of the hands is towards the center of the body. One of the things that happened with her as well is that although she had a reasonable amount of speech when she was about 2, there was a period where she was losing that speech, and instead of talking was starting to do a lot of kind of screeching. And Mom remembered that period really well. Her communication now is much less with language and much more by using her eyes. So she has great eye contact. She'll look at you. She'll look at what she wants. She does a lot of communication with her eyes. And somewhere along the way, she started to have some seizures, although they're pretty well. So Mom came to clinic. Her family doctor had kind of said, well, I don't know that there's any reason to keep looking to try and understand why this happened. But Mom really wanted to find out, so she managed to get a referral for genetics. And the testing showed that she has Rett syndrome. Now, Rett syndrome is caused by a change in a single gene. So you have to look for that particular genetic change. But knowing that you have that genetic change gives you the diagnosis. So she has Rett syndrome. Mom, again, said that she was relieved because she had worried about some of the things that had happened when her daughter was quite young. So it was helpful to her to know that this was something that was out of her control, in essence. This is a condition that sometimes can be inherited. So in other words, some women can carry it but not have the condition. And so you can test the mom to find out if she's a carrier or not. Because, of course, if she's a carrier, then other children that she has can have this condition. Most of the time, the moms are not carriers, and that was the case in this situation. One of the things that we know is that there are problems with the autonomic system. So in other words, things that control your heartbeat, things that control your breathing, things that control your breathing when you're sleeping, those sorts of things can be a problem. And so when the diagnosis was made, an ECG was done, and it showed that she had a condition which is called long QT syndrome. And that's not uncommon in women with Rett syndrome. And for those women who happen to die young of this condition, it's often because of long QT, because it causes an arrhythmia, and so the heart stops and they pass away. So it's one of the things that you want to know about before you start to do surgery and use medications like the anesthetics. So that's something that was done that might not have been done without knowing the diagnosis. It's a neurodegenerative condition, so you know that she's lost some skills, that she's losing some mobility, and it's a really difficult diagnosis to deal with, particularly because you know that there are going to be further losses, even though she was actually pretty mild in comparison to the other families and daughters that this mom then went on to meet. She could see that her daughter was actually doing really pretty well, but still she had to deal with the idea that her daughter is going to continue to lose skills. There is an Ontario Rett Syndrome Association. There are clinics, one in Chio, one at Toronto Western, and there's a lot of positive research going on across the country. And in fact, this mom was very helpful in, she joined the Rett Syndrome Association. She was helpful in putting together a conference that took place in Kingston, and she's just very active in the group and in trying to let caregivers, primary care providers, and so on know about some of the research that's going on with respect to Rett syndrome. And I just throw this in because we know that in mice who have this MECP2, so that's the gene that causes Rett syndrome, you can breed mice where you can turn this gene on and off by giving them certain medications. And when you turn the gene off, the mice develop the same kinds of neurologic changes that a girl with Rett syndrome develops as she's getting older. If you turn the gene on again after you've turned it off, then the mouse will return to pretty much the state that it was in before you turned that gene off. So in other words, the gene's still there. It's still possible for it to function. You don't have so much damage that you can't go back. And so turning this gene on again, the idea that you can turn it on and that there's sort of a brain waiting to function normally again, is an amazing concept to me, and it's something that people are certainly working on trying to figure out how you could possibly do this in a person. We obviously don't have the mechanism to do it at the moment, but there is a lot of research going on in these, particularly with respect to single gene changes. So those are just examples. And hopefully it's given you an idea of what it is and why you would look for a genetic cause, and that there is usefulness to this in looking after somebody from a medical point of view. There is also from a behavioral and psychiatric point of view. And our technologies are rapidly expanding. Things will be different in 5 years than they are now. There's a lot of change going on, and hopefully we'll just continue to be able to improve in the kind of care we can give people. This is a very small smattering of resources that you can use. This is where the Health Watch tables are. Gene Tests is a place that has a lot of gene reviews on specific conditions, and it's a go-to place for most geneticists. And then these are just examples of some of the support organizations that are out there that are helpful for families and for professionals alike that you might look at. And so thank you very much. If you have any questions, I'm happy to try and answer them, or any comments.
Thank you very much, Cynthia, for that. I learned quite a bit. That was really excellent. I guess in the past what we've tried to do is do this by region. So I know there's quite a few people joining us from British Columbia. And Brianne, I didn't forget that you're on the telephone. Did your group have any questions for Cynthia?
No, that was a really good presentation. Thank you.
Thank you,
I don't
Cynthia.
think we have, do we have any questions? No, we're good.
Very well done.
Thank you.
Anybody else from BC? Doesn't sound like it. Okay, so I don't think we have anybody from Alberta, Saskatchewan, or Manitoba on today. So any of our participants from Ontario have questions for Cynthia?
I have a question. Kathy from ChemH.
Go ahead, Kathy.
I'm wondering if you can comment on some approaches to behavioral management. You mentioned that trying to work with a person to have them change their behavior is not usually realistic, so it's more helpful for staff to change their approach. And I'm wondering if you can comment on that.
I'm not sure what you mean, specific things you would do?
Yeah, just if there's particular approaches that the literature describes that are helpful in this area.
Okay. So the way that I think about it is I think that it depends on what the condition is. So if you look at the behaviors in somebody who has Smith-Magenis, they're not the same as the behaviors you might see, say, in someone with Prader-Willi. So a lot of the approaches are developed depending on what the condition is, which I think is why it's really valid to look at things like the PRISM's website, where they will often have developed specific descriptions of what the approach should be. I'm not sure that it sort of sounds like a bit of a cop-out, but I think that's true. While there are some behaviors that are going to be pretty similar from condition to condition, what I'm aware of is that, for example, with Smith-Magenis, they have very detailed descriptions of an approach to behavior management, often in an educational setting, but that would work in whatever setting they're in. So if you have a particular condition, that's what I would look at. I would go to those support websites and see what they have, what they're talking about. Does that answer your question?
Yeah, I guess in the case where you do know their condition, it's really helpful. And yeah. I don't know how many. I'm not that familiar with dual diagnosis, so this is a new area to me, and I don't know how many people we would actually have that information on in terms of knowing what their genetic condition is.
No, and I think that's why it's really valid if you don't know to say it's important to find out, because there may be, I mean, you may not get an answer. Probably half the time we don't get an answer. But when you do, the potential is there that you'll have that body of information out there, and unless you look, you won't know. So even though they're adults in your system, it's still worth thinking, okay, well, what about genetics? Can we figure out what the cause is? Because you're no longer looking at physical features that say this person is different, so we're going to do a genetic, you know, they look different, so we should do a genetic assessment. It's not really valid so much to look at it that way, because often the physical features really aren't there. There isn't much. And so the only way you're going to know if there's a genetic etiology is to do the assessment.
Okay, thank you.
Okay.
Okay, Cynthia, we're losing a lot of participants because it's 1 o'clock. We went just a bit over time. That's okay. I think that was a great presentation, and thanks again for doing that. We'll be sending out a survey to all the participants to get some feedback on the presentation. Terry Broda, Terry, are you on the line? Can you talk at all? Maybe you can only see. Terry Broda is on the line, and she will be doing the same presentation but in French in December. I believe it's December 3rd that she's doing her presentation. And so thank you, everybody, for joining us. And I think it actually worked out extremely well with the use of the GoToMeeting program. And thanks again, Cynthia, and all the participants. And we'll see you, hopefully, all in December.
Great. Thanks very much, Rob.
Take care.
Bye now.
Bye-bye.
Bye.